Okay, so welcome to the next edition of Complete Physio podcast. And I'm joined today by Mike Brent, who's one of our highly specialised physios here at Complete Physio. If you just want to say a little bit about your background, please, Mike.
Yeah, my name's Mike. Obviously, physio, graduated in 2012. Went through the NHS, did my junior rotations, then started going into the private sector, spent a fair bit of time in professional rugby, and then came to Complete about 5.5, 6 years ago now. So,
Excellent.
Been a good journey.
Mike's here to talk to us today, particularly about rugby. And that would include tag rugby as well, all forms of rugby.
Yeah,
all forms of rugby. Okay, so Mike's going to be talking to us about rugby and rugby-related injuries. And you play rugby yourself, don't you, Mike?
Yep, I play normal rugby and tag rugby. So I say normal, I mean rugby union, not rugby league.
Okay, excellent. So we just want to start things off really, as we do with all of these sort of deep dives into particular sports. And just tell us a little bit about what you would say is unique about rugby as a sport, and I guess the sorts of people that you will see in clinic with rugby injuries, really.
Sure. I guess the unique thing with English sport, obviously in other countries it's different, is just that the contact and the physical side of it. I mean, there are other contact sports when you talk about rugby, you talk about football or hockey and stuff like that. But in terms of the collisions and the amount of beating the body takes, is quite unique in the English sport. So there are obviously the stuff like the concussions and stuff like that, which is going to happen with anything like that. But as a physio, obviously we don't have a huge amount to deal with those unless something escalates. But a lot of it is a huge amount of shoulder injuries, which again, mostly contact based. So you're looking at stuff like ACJs, a lot of the odd dislocation, some other trauma stuff, a lot of knee injuries, just again, because of the height of the tackle and stuff like that, often gets hit around the knees. So equally being a winter sport, pitches can be a little bit suspect, especially if you're playing lower leagues.
Yeah.
So a lot of stuff like that. And yeah, the other side and the hot topic at the moment really is kind of head injuries and concussions. But again, obviously limited part to play with that. But there is some stuff we can talk about and go into that if we need to.
Yeah. Okay. Brilliant. So just because not everyone will necessarily know what an ACJ is, if you can just talk us through where that is on the body, what happens, and how people might know if they've injured their ACJ.
So the ACJ is the acromioclavicular joint. So again, it's just the clavicle or the collarbone coming across and attaches onto just the acromion, which is just the edge of the shoulder blade on the side. So again, normally when people get this pain, when it's quite acute, it can be a little bit more spread, but generally it's kind of just on top of the shoulder, just on a little bit on the inside. Particularly predominant, and really common in rugby just because of the way the game's played. So it's normally like a heavy contact on the tip of the shoulder. And again, it can happen in one of a few ways. If you're going into like a ruck or a tackle and you don't hit quite with the meat of your shoulder, you hit on the side, that can happen. Or a lot of heavy falls, whether you're getting tackled or a bit uncontrolled, landing right on the tip of the shoulder, they're the classic ways that these things that happen. As I said, generally it's pain on the top of the shoulder, normally quite well localized, to be honest. And the key things we look for with it is, one is often there's a bit of what we call a step deformity, because the injury is between the ligaments holding that collarbone down. So if those ligaments are either stretched or partially ruptured or fully torn, the collarbone tends to tip up a little bit, then you get this classic step kind of shape on the shoulder, which is a really telltale sign. Other things we often see is real trouble elevating, lifting the arm.
Yeah.
Having or carrying anything heavy, because that can pull down on that shoulder joint and really stress those ligaments and maybe partially torn. Or the classic one is what we call the cross adductions, what we call the scarf test.
Yeah.
So they're the easiest ways. Also internal rotation, so reaching behind the back can irritate, but that's quite prevalent with other shoulder problems, so not so specific.
Okay. And what would be the role of physiotherapy, would you say, for these types of injuries?
For sure. So there are two options with it, really, depending on the grading of the injury. So they use the Rockwood classification, which has kind of 6 different gradings of it. And I won't go into too much detail, but 1 or 2 is always non-operative. They do incredibly well, and that is purely a physio's job to rehab, really. And again, depending on the level of the athlete or how quickly you want to get back into, there are different options for that. Grade 3 is a slightly grey area. And again, it depends on a couple of different things, but mostly pain and function.
Yeah.
Because we know that a lot of grade 3s do really well conservatively. But if they're really struggling with kind of elevating or lots of pain and they can't seem to control that, some will opt for surgery. And then 4 to 6 are always surgical, just because of the grade of the injury. Normally there's displacement of the bone, so it's not in alignment anymore. And often there's some soft tissue inclusion with that as well. So they're normally surgical. But whether it's conservative or they go surgical. There's always a role for us to play. It's either we do all the rehab because they don't need surgery and we can make that shoulder recover as much as possible, or it's a post-operative rehab. So either way, if you have an ACJ injury, you're almost definitely going to need to see a physio.
Okay, excellent. And so other commonly occurring injuries that you would say linked with rugby?
Yeah, so I said a lot of knee injuries.
Yeah.
ACL seems to be on the rise, and again,
Okay.
bit of a hot topic and,
Yeah.
and a particular interest of mine.
Yeah.
MCLs also, so that medial collateral ligament on the inside of the knee, because a lot of kind of hitting on the outside of the knee,
yeah.
very prevalent as well. As I said, a lot of kind of head injury, concussion stuff,
Yeah.
Which thankfully is starting to we're starting to get on top of that. And then quite a few ankle injuries as well, again, because of the pitch and the pace and, and feet getting hit with ankles and stuff like that. So they're pretty common injuries.
Okay. So we're going to go back to the knee.
Yep.
And we're going to talk about a couple of the more common knee injuries that you would see.
For sure.
So ACL, how does that tend to happen in rugby? What's the sort of most common mechanism that you see in rugby?
Sure. So that's a bit of a misnomer, really, because I think a lot of people assume it's going to be heavy impact on the side of the knee, but the vast majority are non-contact.
Yeah.
Again, with rugby, most of the time that happens is when people try and have a sudden change of direction. So if they're trying to kind of plant their foot and sidestep away, or landing from a high ball that's kicked up and you land a little bit awkwardly, it's normally when that knee lands. The most common mechanism is if your foot kind of gets a bit stuck and you go to torsion. We call it a pivot shift mechanism. It's just when the two bones just get twisted, essentially, and that can rupture the ACL. The other more rare common is the way that it can happen is just that hyperextension where that knee kind of folds too far backwards. It can also occur.
Okay. So I'm presuming that, and you mentioned also MCL injuries.
Yes.
So just tell me a little bit about that's on the inside of the knee.
On the inside of the knee,
Yeah.
And it often happens with an ACL, to be honest, because of the torsion.
Right.
But the biggest reason why I see them if it's an isolated injury rather than included as a secondary is just someone getting hit really hard on the side of the knee. Normally with a foot planted, because then it can kind of just open that joint a little bit and can damage that ligament and stretch or potentially rupture that.
Okay. Any particular considerations for someone who plays rugby in terms of when they're having their ACL repaired?
Mm-hmm.
Do they tend to go for a particular type of graft, or?
It's a good question, and there are a few different graft types available. The thing I often say to everyone is that if you found a surgeon that you know is on top of their game and is a very good quality surgeon, they have a preference, go with it.
Yeah.
There are other times when you may think there's a preference for one over the other. There are some examples you can say cultural, if you're kneeling a lot because you pray, you don't really want the graft coming from that patella or quad tendon because that's going to be quite painful. Yeah. Depends on the quality of the tissue around the knee at the same time. But the vast majority would say we'll go for hamstring grafts. That seems to be the most common graft. But again, it kind of comes in waves and trends as well. And I'm sure you've seen that over the years. It seems to kind of change. But ultimately, from all the ACLs I see, and I see quite a few of all the graft types, as long as they do what needs to be done from a rehab point of view, they do really well. So I always say to everyone, don't worry too much about it. The surgeon probably has the best knowledge on what's best for you or what their best technique is.
Yeah.
So don't get too bogged down with it. Say, unless you go into the elite standard where it's a bit different.
Yeah.
If you're a jumping athlete or something like that, you probably don't want to have the quad tendon done. If you're a sprinter, you probably don't want the hamstring done. But generally across the board, it either works.
Okay. With the medial collateral ligament injuries, can you tell me a little bit about those grading systems, how the different levels might be managed?
Sure. Yeah. So with the MCLs, to be honest, the vast majority do really well conservatively. I mean, even when we know they're fully ruptured, which is normally done via MRI or ultrasound scanning, but also clinically tested with the stress test, most of them do very, very well without any kind of surgery. Often what we'll do, if it's kind of grade 3 or above, which is we're thinking there's quite a lot of the tissue that's been ruptured, we'll brace it for the first 6 weeks just to stop any kind of twisting or gapping or stress of that ligament, just to keep the knee nice and linear. And then it's nearly all rehab based. The only time we would ever go for a surgical opinion or something like that, if there's really, really notable laxity in the joint, as in that ligament is so far gone and the supporting structures aren't good enough to stabilize the knee, then surgery is an option. But I've found over the years that the vast majority, even when they're grade 3, generally do very well conservatively.
Okay, excellent. And so just in terms of knee rehab generally, I'm thinking particularly that sort of more return to sport. Anything particular that you need to focus on in terms of getting someone back to playing rugby, would you say?
For sure. So number one is quad power and quad strength and output. It's again, if you look at a lot of the research and the statistics, it has a massive part to play with especially with rugby players with knee health and reduction in injury chance. So again, there are some outcome measures you can look at. We would use our handheld dynamometer to look at symmetry between left and right. We know if one leg's, we use that as a baseline. If it's a healthy leg, we want at least 90% quad power looking at the other one. If we're going to talk more slightly ACL specific, hamstring is really important also in the relationship between the two. Because the quad and hamstring, obviously they give far more stability to the shin bone than the ACL can. So if we get a good relationship and ratio between the two, also compared to asymmetry on the other side, that's really, really important. We also spend a lot of time on landing mechanics and movement patterns. Which is really, really important, and something I think isn't particularly well done, especially in the more amateur side of sport, because people aren't really trained on landing mechanics and what we call their plyometrics, their ability to repeat movement patterns and be efficient with that and try and reduce the amount that knee contortion. And again, at Complete, we have our force decks, which I use a lot, which can look at landing mechanics and the way that people jump in terms of their technique, which you really can't eyeball too much. But with the force decks, it can break down both their jumping, their landing, again, their plyometric capacity within their knee and their lower limb. And that is a really good measure to use to know the knee health and the efficiency of that knee as well. So they're all the things I would look for with our return to sport, as well as some of the more normal stuff in terms of sprint speed and that kind of stuff.
Yeah. And for your rugby players, how do you sort of bridge that gap between sort of getting people back to some sort of contact? I could imagine there, particularly after, say, for example, an ACL, there's going to be a lot of anxiety about getting back on the pitch again. How do you work on that?
Test and retest to begin with is really important, just so you can prove to people that their knee is functioning very well. Because if you haven't actually tested and proven to them that it's as strong as the other side, or at least that 90% is really what we look for. Repeat. A lot of ACL stuff, particularly I find, is confidence. Even if the knee functionally is brilliant, people still have kind of lost trust in that knee also. But if you can repeat something time and time again, grade their exposure progressively to build up their confidence to it, it's the best way to do it, both from a strength and control point of view, but also the contact side. As 6 months onwards, they should be back in their club, not necessarily doing contact stuff as of yet, but there's a lot you can do after 6 months of surgery that you can get into. And just being around the environment, again, I find is particularly useful. If you just hermit yourself in a gym or away for 9 to 12 months, never even step foot on a training pitch and don't get around that at all, often makes people anxious as well. And again, it's just that graded exposure, just allowing small bits time and again, slowly ramping things up to allow both the knee to adapt, but then to mentally get comfortable with the idea of being back in that situation again.
And I would imagine as well that, if you're away from rugby for 9 months, then you're going to lose a lot of the conditioning for the rest of the body as well. So it's the upkeep of that as well.
And that's why I find going back at their clubs as soon as they are physically and biologically capable is massive, because it's like dangling that carrot again. You can kind of see the end goal, and I find it really motivates people to kind of keep going and push on, because it can be quite a long process, and we do say at least 9 months, because we know that's how long it takes for that graft to be as stable as we can and start to really mitigate those re-injury rates. But if you do, if you're not involved, it can seem quite isolated. So I always encourage people, as soon as we've assessed them to be good enough, to start doing some of the basic stuff. And we always put obviously parameters on stuff. But I try and get them back into that environment so they can start thinking about themselves being back in that environment again.
And I presume like lots of just training, getting used to being tackled, but in a kind of like much more kind of like controlled environment.
100%. And in most teams these days, we've really kind of tried to drop the amount of heavy contact we do, because there's a lot of research showing that a lot of injuries are cumulative sometimes, when there's no need to go and wallop each other on a Wednesday when you've got a match on a Saturday. I think the thought process before was, if you haven't done lots of heavy contact in the week, you won't be putting a shoulder in at the weekend. But we know that's not quite the case anymore. So generally there's a lot of, there's a bit of a swing to some less aggressive work in training sessions anyway. But equally, if you've got a player who is trying to get back into it, I often advise them to take a player or a friend and just start doing some gentle work so it can be really controlled. And just reduce the intensity. And there's ways you can do that.
Okay, excellent. And do you tackle them in the gym at all?
I've been tempted. No, I haven't. No, we don't have crash mats.
Excellent. And so do we know anything about, because I know, with people that are returning to very high level sport after ACL, there's oftentimes a lot of anxiety about re-injury.
Yes.
Is there any data about sort of rugby specific re-injury of ACL?
That's a good question, and I haven't seen a rugby specific paper. There is more with football, I believe.
Okay,
but football has money to pour into research.
Yeah.
Rugby is not quite as financially sound, so that there isn't a huge amount. The good amount of research we have in rugby, particularly, is concussion based.
Okay.
Mostly because of the litigation that came out from that. But I don't actually know if there is a study on purely rugby players' re-injury rate post ACLs. But from what I understand and what I have read, I know it's comparatively lower than a lot of other sports. But I think a lot of the reasoning for that is just in terms of the size of a lot of the players.
Yeah.
And again, if you look at a lot of the research, that muscle depth, I said previously about quad power, has a really good link to reduction in kind of cases.
Yeah.
And generally, you'll see with rugby players, they generally have a lot more, which means they have more to, they can afford to lose more, and then it's easier for them to regain that. And that is quite a big factor.
Okay, excellent. Let's talk about ankle injuries.
Yep.
So any particular commonly occurring ankle injuries with rugby players?
I think it's the same with most team sports.
Yeah.
To be honest, there's obviously that kind of the outside ligaments on the ankle spraining happens regularly with all these sports, just because of the speed and the pitch type and that kind of stuff. I think it's pretty prevalent. There's nothing particularly hugely different to most team kind of grass sports, to be honest. Potentially that the fracture rate is a bit higher, just because if you're on the floor and stuff, and there are lots of feet flinging around and stuff like that. But I wouldn't say there's anything particularly prevalent or special about that really with rugby.
So you're seeing predominantly sort of lateral ligament injuries of all different sort of gradings,
Absolutely.
So sprains and strains all the way through to complete ruptures. And again, if we just talk a little bit about what someone can expect if they're coming back from a lateral ligament injury.
Sure. Yeah, and again, lateral ligament injuries generally heal particularly well. I say the two main ligaments that we injure are the ATFL, which is the one at the front, and the CFL, which is the one that's slightly more underneath. And again, I see plenty of people who have ruptured both and be put in a boot for a while, conservatively managed, and normally do really, really well. And again, the rehab pathway is, again, it's just about restoring range of motion first, controlling pain and swelling, just so they can get back into a normal baseline and enjoy day-to-day life. Then it's starting to look back at making sure we can regain the strength around the ankle, looking at what we call the proprioceptive ability, or the ability to control that and know where it is in space to balance and work. And then we'd look at the more high-end stuff in terms of jumping, landing, again, that plyometric capacity, and making sure they can control the ankle in all planes and, of all movement types, and making sure they're comfortable with that.
Yeah.
And again, comparing to the other side, always the thing to do.
Now, is there anything that people can do that will reduce their risks of any of these injuries? So I'm thinking about here, either people returning to playing after a while. So we mentioned already, you might be out with an ACL injury, but you're potentially, you're deconditioning generally in terms of your, return to play with rugby, or and I probably assume this doesn't happen too often, but someone who thinks about taking rugby up as sort of a later stage of life. Anything that people can be doing to reduce their risk of these common injuries?
Yeah, I mean, there's a really, really, really good kind of prehab and kind of preventative measure that's out there that's very rugby specific, and it's called the Activate Programme. And it was developed post research, after research, and again, it's for both school kids and for older age, and obviously it's different between the two. And if you go on just like the Rugby Football Union website, the RFU website, you can find and you can get access to it. It's a brilliant tool. They did some again, it's mostly research based, and they found that with school kids who followed the Activate Programme in that program, I think overall injuries reduced by 72% on the pitch.
That's
concussion
amazing,
head injuries by 59%. And then with the adults, I think low limb injuries were 40% reduction. Concussion rate dropped at 60%. And the program, obviously it's tiered, so it depends on your age group, and it goes from under 7s to under 18s. Every year group has a slightly different thing dependent. And then adults have the own basis there. There's several components to it. So there are 8 kind of body positions and techniques it teaches.
Yeah.
Because again, in rugby, if you look at concussions, particularly head position when you go and do stuff is the number one reason why they happen, really. So it's about body positioning and technique. And then the exercises and the game-based scenarios that is based on is all rugby specific, looking at moving properly, understanding good technique, good postures.
Yeah.
And then warming up the relevant body parts, including coordination and stuff. So there's an exercise-based version of it as a warm-up, and then there's lots of game-based scenarios, which again, as a coach, there's a fair bit of license with. There are some key principles it teaches to try and include, but then you can bring into a game-based scenario, which again also really helps. Because if you tell someone they've got half an hour to do these boring static exercises, quite hard to buy in. But with this, it's a lot more game-based with approaches and with ideas that you need to try and instill within it. And again, even if you've never played rugby before, it's a great place to start, because it will start teaching the important body positions and techniques of the basics of the game, and also how your body should feel and the way that you should warm up properly before a game. So it's a really, really good program. And so there's lots of material out there for it. So.
I've seen something, I think, similar. I don't know if that was football specific, but exercises for reducing knee injuries. So
I think it's a FIFA 11 plus. I think
that's
is what it is for football.
And again, some amazing data coming out in terms of reductions of injury rates.
And it's a similar principle, right? It's just going through basic techniques and movement patterns that you're going to expose yourself to in a game, making sure you can optimize those as much as possible, and then making sure the body is warm. All the key areas of the body that are important for injury reduction are prepped and primed, ready for the game, rather than being cold and a little bit stiffer.
And I would imagine a lot of it's using a lot of the same principles. And as you mentioned earlier, this kind of, the sort of intuitive thought that most of the knee injuries, for example, are going to be contact. Whereas I know with the football protocols, there's lots of exercises around turning and pivoting and
landing. Absolutely. All of that is right. I think it's something it's around, off the top of my head, around 90% of ACL injuries are non-contact injuries. Most of them are relatively innocuous looking. And yes, you're right. A lot of it is about that technique and the efficiency of movement and understanding the way to move and how to plant a foot. And I know it sounds quite basic, but I don't think many people are properly taught that. Or do it in their warm-ups. They generally just kind of run around a little bit, hit a couple of bags in rugby, maybe swing their arms a little bit, make themselves feel warm, but they haven't actually looked at their control.
Anything around sort of boots and footwear and stuff, because I know that a lot of knee injuries in rugby come from sort of pivot, turn, foot gets stuck in the mud.
It does, and I think boot types and stud types make a difference. There's a reason why there are soft ground boots and hard ground boots and boots for 4G if you're playing on it, or 5G if you're playing on an artificial pitch. So again, important. The other thing that comes out of that, which is really interesting, if we talk about women's rugby, which is on the rise, which I'm a huge fan of, boots are designed for men's feet. Men's feet are different to women's feet, just in terms of their size and shape and ratios. So there are now some boot production companies that are purely designed for women. I think IDA's one of them, IDA. And I think there's another couple out there. So again, if you're, a girl playing rugby, have a good look. Because it's different.
And are we seeing the same? Because I know, in football, that the injury rates in female football are way higher than male. Are we seeing the same patterns
pretty
in
much
female
across the
rugby?
board? And again, depending on which paper you read, if we talk about ACLs, because I said it's why I spend a lot of time on, it depends which paper you read across the board, 3 to 8 times more likely.
Wow.
In ruptures in terms of that. And again, we don't exactly know why. We've looked at 1,000 different things, and there are obviously some biological reasons as to why in terms of hip angles with them. Men have generally 50% more muscle mass across the board, which we know is a good factor in reducing injuries. They've looked at stuff like reactive times in terms of how quickly a muscle can contract, which is slightly lower for women as well, just biologically. But I also think that if you look at the social side, of stuff, if you look at a rugby player now who's 22 and playing professionally, they've probably been coached and had lots of high-end input from the age of 9, 10, even up to, when they get into academies. They've had years to practice their movement patterns and stuff like that. And historically with women, they've started later. So they haven't had those those early years when they've been drilled into good technique and rapid acceleration, deceleration, movement patterns. And I think that has a part to play. But thankfully now, the English rugby team anyway is professional. A lot are going that way, and that money's starting to filter down. And I think that will really help as well.
So may even be particularly some of the stuff we were talking about earlier in terms of the preventative stuff with, rugby injuries potentially, very important for female rugby players as well.
Hugely.
Yeah. And particular things in terms of, muscle strength that they can be working on potentially.
Yeah, exactly. Because again, classically, because of the way that the culture and society has gone, it's not particularly a seen thing that lots of women go and strength train. If you look at the gym, it's mostly blokes on the free weights and ladies in the cardio, which I think is ridiculous and is thankfully starting to change. But being strong is never a bad thing. And I think culturally that will change. And I'm hoping as it becomes normal, injury rates will drop away.
Yeah. You mentioned culture. I'm really interested in the different sports, and it's been really interesting talking to some of our different sort of physios who have these real sort of specialisms about that sort of culture and mindset within a sport. Now, I've treated a fair few rugby players over the years, and I was actually pitchside physio. I was one of the first sort of side hustles that I had when I first qualified as a physio many years ago, and so I'm very aware of the sort of like some of the culture and mindset differences and how that might impact upon injury management. So, anything that you would say about that, Mike?
Yeah, on the whole, I think a lot of rugby players try and hide things because they're so keen to play, which is that what you found as well?
Yeah, 100%.
Which can be tricky because ultimately if there's no outward signs that there's pathology or a problem, a lot of our basis on return to play and that kind of stuff is based on someone going, does it hurt?
Yeah.
If they say no, there's no test for testing pain.
Yeah.
So that is a bit of a problem. And if you go right to the elite standard, or even when you're playing at those upper levels, there's a lot at stake. There's a guy on the bench waiting to get on, and I think there's a lot of fear of losing your place or looking like you're not tough enough to get on the pitch, which is a problem. So that can complicate things a little bit. But again, I think it's slowly starting to change a little bit. I think people realize longevity in sports is really important, as is your life after.
Yeah.
If you look at the age of retiring rugby players, it's not particularly old.
Yeah.
I think I'm one of the oldest in my first team, if not the oldest. So that's nerve-wracking.
Yeah.
And again, money's not in it really either. So got to look at the long haul, really.
Yeah, no, I mean, I know you do a lot of work with dancers as well, but I always draw a lot of parallels between rugby players and dance in terms of they're just, it's the mindset, the culture is,
push the pain away.
Yeah. And you just carry on. And like you say, there's always someone in the sidings to replace you if you come off. And that mindset, that culture, I think sort of, really sort of lives within those sort of sports and disciplines. It's very interesting, and I think it's really important that the physio and the medical team around the players and stuff are aware of that, because I think there's a lot of probably underreporting of injuries. Yeah. And certainly like the sort of pitch side, it's just sort of strap me up and I'll go back on.
Absolutely.
Which takes us, I guess, as well onto this whole thing around sort of head injuries and concussions.
Yes.
So can you tell us a little bit about linking that into, obviously, rugby is a big area, obviously, within rugby.
Yeah, and you're right, it is a big problem. And that's one of the biggest reasons why it is a problem. Is the thing, a lot of lads, get clean knocked out, but they wake up 10 seconds later, no headaches, don't feel dizzy. And they go, well, I'm not concussed then. Yeah. You are. Yeah. If you've lost all track of what the heck's happened in the last 10 seconds, you've been concussed. And again, there are some brilliant stuff out there for the RFU and the World Rugby kind of websites. And the thing we look at the moment is something called Head Case, which again, you can go and look at, and it's got loads of really, really interesting and important information. But as a rule of thumb, if you've had any concussion, minimum 2 weeks off. Doesn't matter how you feel. You can feel great. You can feel amazing. You should not be playing for 2 weeks or training and doing any contact stuff at all. That's just across the board. Where that changes is your concussion history. Yeah. So what we look at is kind of more than one concussion last 3 months, more than 3 in the last year, or 5 in your career. That starts changing things in terms of your return to play. Again, irrelevant of how you feel, just because we know the changes that can happen in there. Then it's 3 weeks plus, depending on the protocol that you can follow. Yeah. And again, there are other tools out there that, not necessarily designed for you to be a professional to diagnose a concussion, but to diagnose a head injury, which is a more broad term. and just to figure out if someone has a head injury. And again, if you go on the websites, there are loads of really great, easy resources that you can utilize as a coach or, as a pitch side physio to see, have they got a head injury or not?
Yeah.
And there's some really good, some documents and some protocols to follow to make sure when you return safely.
Yeah.
Again, in the elite sport, we call them HIAs, so head injury assessment. You'll see on the pitch, people get drawn off all the time. There's even a separate referee, like medical doctor on the side of the pitch who's completely neutral now, who if they see something in a game they're not happy with, they'll pull them off and they have to go. Then they'll have a baseline test. They'll have kind of pre-season, so they know what normal for that player is from a cognitive and visual point of view, and they'll retest it. But if you suspect there's a head injury and you're struggling with symptoms, whether it's dizziness or headaches or light sensitivity, or you can't concentrate, sports exercise doctors generally are the ones to go and see. Sure. So a lot of them will have knowledge and speciality in that area.
Yeah. And on the basis, as we say, there's probably a lot of underreporting, and I think people's threshold to go and seek help has been sort of probably way too high in the past.
Yeah.
So your sort of cut-off point, obviously, any loss of consciousness people should go and have medical assessment afterwards. We're saying that. Any other
or any symptoms that like headaches, like almost instant headaches that are lingering. People like struggling to concentrate. A little bit of light sensitivity. Dizziness. All these things. Even if you haven't been knocked out and you've gone black, if those things are happening after a head knock, you're concussed, or you have a head injury, and anything like that, really 2 weeks minimum. And so unless you have a history of repeated events recently or
that's
the past.
That's a really interesting point, because I suspect, and you're saying there's an accumulative effect. So within that particular incident, the head injury might not have needed to be so severe.
Exactly.
But if you've had other knocks in the past.
Exactly. Yeah, we know it's cumulative. We know it's cumulative. So again, if you look at the head case stuff, it gives you the data and the knowledge to know kind of in relatively easy terms what to look out for as a concussion history and what that means. And then the parameters you need to look at to take things a little bit more seriously. Again, even if it's not horrendously symptomatic, it's still something you need to be, you need to take seriously and take control of.
Okay. And so the treatments for these will be sort of like kind of, I guess, avoiding participation in the sport for a time?
Yeah, absolutely. Again, there's a really nice table that you can see on there that kind of goes through 6 different phases of recovery. Like the first one is a complete mental and physical break to allow things to settle. Then it starts looking about adding on more mental stress to begin with, and then light physical training, and then it just starts ramping things up depending again on your testing, on what you're showing and where you're struggling. And again, there's a really nice little 6-phase cycle, and again, it's not a protocol. It is not particularly time driven. It's not like a soft tissue injury where we're waiting for a tissue to recover and we wait for these biological processes which we've researched and we're very, very clear on their time frames. It isn't a protocol like that. It is just a pathway to go through, and you step from one to the other when you hit the parameters we're looking for. And it doesn't matter how long that takes. It's when you're ready and we can test that you're ready rather than when you think you're ready.
Okay. Interesting. And, really, really important for people to be aware of that.
100%. I said there's so much good information on World Rugby and the Rugby Football Union website that, ignorance isn't really an excuse anymore. There's lots of stuff out there that's easy to follow.
Going to ask you about some of the more recent modifications that have been made in the rules of rugby. Are we seeing any sort of changes in terms of like injury patterns and?
A lot, yeah. I mean, the biggest rule that we've seen is the tackle height. As far as where you can tackle, now it's kind of sternum and below. Previously, you could kind of wrap around the shoulder or something like that, but now that has been completely removed from the game, so it's kind of like sternum and below. We are seeing a lot more penalties and because of it, but ultimately, good tackle technique anyway should always be dropped anyway. There's not that many reasons to go high. Can be a bit frustrating when you play because you feel like you put a good hit in. Again, guilty of it sometimes, but ultimately, but sometimes it's that split second, between someone dropping and you not dropping. But if your body height's crap to start with, you're in trouble. If you bend at the hips and someone dips again, there's always mitigation. But that's changing. Stuff in the scrum's always changing. Every year there seems to be new rulings with that. So they're trying to make the game as safe as possible without taking away the physical side of the sport. And I think it is a careful balancing act. But ultimately, we want to try and reduce those serious injuries as much as possible.
It's like you say, it's like Formula One or something, isn't it? On the one hand, obviously, making safe.
Yeah.
But sometimes
You
there's
can't
that
limit them to
balance.
50 miles an hour, can you? Because it'll be fun to watch.
Yeah, exactly.
You know, and rugby ultimately is a contact game, and there is some responsibility of a player who wants to play saying, I accept the risk. You know, you don't go into a boxing match expecting never to get hit in the face.
Yeah.
You know, and ultimately in rugby, things happen, accidents do happen.
Yeah.
So you've got to understand that when you go in, but there definitely should be as much mitigation as possible without changing the game itself.
Sure, yeah. And I know that you play a lot of tag rugby, and you see a lot of tag rugby players. We've talked about the fact that by no means are all rugby injuries relating to sort of contact. What would you say are the differences, if you like, in terms of injury, but also I'm thinking like return to play with your tag rugby players?
Return to play, a lot more would be about speed, footwork, and those landing mechanics are even more important. And in fact, I'd say in tag, ACLs are more prevalent.
Wow.
Purely because there's a huge amount more acceleration, deceleration, change in direction, you know. In rugby, again, it may sound a bit brutal, but often you don't have to decelerate that hard because you get hit anyway, you know, so you don't rely on your knee to actually have that huge deceleration brake force in it. Whereas in tag, you know, it's a non-contact sport. Obviously, there's the odd little knock. But because it's so much quicker and there is no contact and it's more about evasion than necessarily strength and force sometimes, I'd say the ACL rate's higher.
Yeah.
Also, a lot more girls playing in it, which is brilliant. So that also bumps those numbers.
Okay. And just in terms of, I was going to ask you a little bit about just the different age groups, if you like. So obviously there are sort of criteria, aren't there, in terms of when what age people can start to do contact, and then they gradually bring in the scrum and the line outs and so forth. Any thoughts on that with the sort of younger players and obviously in particular relation to injuries?
Again, I think a lot of it is just technique based. You know, they've just got to be drilled into technique. We're not expecting those guys to be in the gym getting strong. You know, that's not the most important factor at that age. Everything's about technique, you know, in terms of head positioning and for you know, for tackling and all that kind of stuff. And again, working early doors on their ability with their footwork and understanding how, you know, how you can both best perform. Which also leads into having less injuries. The better technically you are, you know, the better the forces going through the legs are. So it's just all technique at that age. Absolutely.
I want to ask you a little bit about shoulder dislocation injuries, because I know that, again, that's something that unfortunately is a bit of a
higher prevalence.
So if you're seeing somebody for the first time and they have had a shoulder injury, might be unclear, was it dislocated, sublux? What's the, if you like, the sort of protocols around when they need to get a scan, when it can be sort of rehab based, or when somebody may be sort of looking at a more sort of invasive form of management?
Sure. So with the dislocations itself, again, it also depends a bit like with concussions on previous history. You know, we know that if you've had a dislocation episode or even a subluxing episode before, you are more likely to have a repeat just because of the ligamentous structures never quite recoil back to the beginning. And whilst you can compensate with that dynamic stability element, looking more at the cuff and the muscle stuff, that static element of stability never quite returns. So that would always change my thought process. If it's a really acute one and you're not really sure, have a quick feel around the shoulder. You know, have a quick look at it visually, because often there is a sign that it's not quite right from a structural point of view. If you're in doubt at all, get it scanned. It's as simple as that. If it's clearly in joint and you can move the arm without significant amount of pain, again, early stages is all about trying to decipher exactly how big the injury may have been, whether it was a full dislocation or wasn't. Early stages is just gentle restoration of movement below 90 degrees. Just get them move that arm comfortably. Try and get that, you know, that ball or the glenohumeral head rotating around in that socket to try and get that joint moving to begin with. And then again, it is relatively time frame based, you know, because we need to know how long these structures take to settle and heal and what kind of force they'll be ready to accept. So again, I wouldn't really do any particular strengthening work or anything massively above 90 degrees unless they're exceptional before 4 to 6 weeks.
Okay.
And then it is basically time frame and functional based, symptom driven.
Okay. And recurrence rates with sort of shoulder dislocations, subluxations?
relatively high, especially in rugby, unfortunately. But again, I find if you are incredibly diligent with your rehab and you can test it properly, because other things that are important are like, if you look at rotator cuff, which is the most important factor for controlling the stability of the shoulder joint, looking at stuff like internal compared to external rotation ratios important, because internal rotation's a little bit more important in rugby, especially to try and stop an external force. So again, it should always be higher. I'm not going to bore people with those statistics, but again, in clinic, we would test that. We would look at the dynamometry so we can compare the ratio between the two and the asymmetry compared to the other side. We would do stuff with strength testing. So again, the ASH test, which we'd use force plates for, looking at strength in these more exposed positions of the arm as well. And again, all those factors are really important for checking.
Okay. And I'm presuming that with females oftentimes being more hypermobile than males, that we're looking at higher incidence of shoulder dislocation rates potentially.
Yeah, I would assume so, but I don't know the research on that. But
Okay.
I would guess so. But it's pretty prevalent across the board, to be fair. Just because of the forces and the nature, the most vulnerable position for a shoulder is out in this, what we call this Faber position. And when you're making a tackle, when you're bent over, when you're going to score a try or reaching out, it's relatively vulnerable.
Just in terms of last few things that we wanted to ask you about, really, Mike, and that's just in terms of any particular forms of bracing, whether it be like knee braces, shoulder braces, anything like that you ever sort of tend to recommend, or that you...
Not with rugby particularly. No. I mean, you're not really allowed to play with a metal brace on anyway. If you go skiing, obviously you can wear a hinge knee brace, wear it nicely. You can't really get away with it, so it's quite difficult in rugby to do that. More so, people try and strap. And again, trying to strap to prevent an ACL injury, I think, is
not going to happen.
Just because of the forces. It's a little bit of tape isn't going to stop anything. So bracing's tricky. I mean, getting back into it when you're doing non-contact stuff, by all means. But ultimately, you can't wear it when you play the sport. So having that kind of false hope with it on there, and giving you some feedback and then completely taking it away, I don't find particularly useful. So not really so possible. Especially with knees anyway. If you talk about ACJs, like we spoke about earlier, you can definitely, we can fit some padding on the top and then strap down. That can really help offload that joint itself. But again, it's not a particularly mobile joint, and you don't need huge amounts of stuff to try and help with that. But with a knee, not really that possible. Again, wearing sleeves, I see a lot of people wearing sleeves, and again, sometimes give you that feedback, and just that feeling that the knee's got a bit of compression in it, and sometimes it can help people remember to really work on that knee and to make sure they are technically proficient with it when they go to land. That can help to give feedback, but in terms of true stability to the knee, relatively negligible.
Are you seeing many hamstring injuries in your rugby players?
A lot more in tag rugby.
A lot more in tag rugby. Again, just because the amount of acceleration, deceleration that happens. And quite often with those guys, it's quite often the proximal hamstring tendons, the tendon attaching up to the bottom. I see quite regularly. And in fact, I've got a few guys at the moment that I'm treating for that exact pathology. So is this sort of, kind of like in cumulative, or are we talking about like one-off incidents, sort of tears, or what?
Generally more cumulative. In the tag communities, particularly in rugby, it will be more likely to be one-off tears. Like I said, you don't have so many sprints in a rugby game, depending on what position you play. But even if you play out on the wing where you're going to be sprinting more, you're not going to be sprinting every minute. The ball may not get out to you that frequently, but if you're playing tag rugby, you're constantly sprinting throughout the whole game. And again, I said there's a lot more deceleration forces. So it's generally the cumulative inflammatory is what we see in tag rugby particularly.
And just talk me through, because I know you do see a lot of hamstring injuries. Just talk me through kind of how you tend to approach these, all the way from, when they first present back to sort of return to play. What sort of things
in terms of inflammatory?
Just go through your sort of overall sort of program, really. Let's just say it's a cumulative proximal hamstring problem that someone's got.
So the first thing I would want to do is understand its sensitivity and irritability. If you don't understand what the tissue can tolerate and what it's comfortable with, you're essentially just throwing stuff at the wall and seeing what sticks in terms of what's going to be relevant for them. I would need to understand exactly how much that tissue can tolerate from a load and a stretch point of view first. And when I say stretch, I just mean, what phase of the contraction they struggle with, because some may struggle right on the outer reach, some on the inner reach. And again, that will make a difference in terms of how much you load and where you load. Because ultimately what we want to do is make that tendon adapt to accept more tolerance, because with these inflammatory tendons, what we know is they get pain after a certain tolerance, whether that's one particular load or more likely a cumulative amount of load. So if we can improve that tendon's tolerance to stress and eventually it stops being irritable, that's when the pain will start to dissipate and they can get back into their sport. So figuring out exactly where that tendon can tolerate, finding a way to load it to that degree, and then just progressively loading that as we go. I generally use the eccentrics as a whole, just because, again, some evidence suggests that the tendon unit is loaded more on the eccentric portion of a muscle contraction, which is the lengthening rather than the shortening. So that's the approach I will generally take. And once they can do it comfortably from just a static strength point of view going through range, then we'll go through some more dynamic movement patterns. So we can add on that stretch strength on a little bit of speed. And then I generally do a return to sprint program. And again, all based on tolerance. And again, slightly different for everyone. As we said before, because there's nothing ripped, torn, or broken, we're not waiting on a time frame with these. It is purely based on symptomology and tolerance of that tissue. So it varies quite dramatically, and it doesn't always seem to be based on someone's health or capability or physical prowess. It seems to be relatively random. And if they're really, really stubborn to shift, we've got other options. We can try shockwave and, potentially a steroid guided injection with ultrasound if needed. But I find the vast majority do pretty well. The frustration is with a lot of people is it's never as quick as they want it to be. But these inflammatory tendon things, they're never quick, are they? They're never quick.
Exactly.
And it takes a fair bit of diligence and consistency to really start to get on top of it. So
it's probably quite a good time to bring in the fact that you're a sonographer as well as a physio, aren't you, Mike? So you have that added ability to be able to scan through the hamstring, for example, and have a look and see if there is a structural abnormality. Which is massive advantage.
It is. And I find with these proximal ones, it's normally people confuse it with a glute problem or a hip problem because it's quite deep. So I find the presentation of them, I generally don't scan a huge amount of unless I'm worried or so concerned, because normally they go, it's right in my bum, it hurts right here. So there's no soft tissue inclusion. If they're suddenly saying it's down in the muscle belly or a little bit lower down, absolutely have a little look. But you find with a lot of these, they point right up into their bum on that sitting bone where it attaches onto, and it's always quite point specific with those. But you're right, if it was muscular, 100% have a look through and see if you can see anything more.
And sounds, obviously ultrasonography going to be really, really useful with a lot of the injuries that you've talked about today.
MCLs, particularly ankle injuries, particularly even shoulders. If you're trying to rule out any kind of rotator cuff problem, or assessing ACJ for if you think trying to look at the level of step and the gapping between that.
So a great adjunct to have with a lot of these injuries that may have had some sort of trauma, may have had some sort of impact component to them from the first place. So
absolutely.
So you're integrating your clinical assessment with your ultrasound findings, being able to give the patient that level of reassurance. The hamstring, there's no actual structural abnormality with the hamstring. We're good to start loading it.
Exactly. I said it's a hugely useful resource, not to necessarily track how well something's healing, because we know that doesn't work, but diagnostically it's huge. And even if it's just someone's particularly anxious, and you can just show them physically that actually the structure around it is absolutely fine, I find that people are much more confident to go and load that tissue and to work on it. So, it can be invaluable.
Going on from what we're talking about in terms of like culture and mindset and the uniqueness of rugby as a sport, we just talk a little bit about the differences and the range of demands, if you like, for people that are playing in different positions in rugby.
Sure. Yeah, I often get asked, from people saying, what can I do to really improve my game? And the first question I always ask is, what position do you play? Because someone says, I think if I can be really, much quicker, it would help. And for some positions, absolutely. For playing out on the wing, anywhere in the back line, particularly, speed is hugely useful. If you're playing front row, yes, you want to be explosive over a short distance, but in reality, you're not going to be hitting top speed in a game. So your absolute raw speed if you're playing in that front row, isn't going to be particularly valuable. But then if we talk about, unbelievable strength and explosive power, again, useful across a board to a degree. If you're, again, that front row, you need to be incredibly powerful and incredibly strong to compete physically. If you're playing out on the wing, or you're a scrum half, for example, where your game is more built on speed and agility, yes, power is going to be really important and you shouldn't neglect it. But maybe it's not the biggest factor that will make you progress as a better player, especially if you're trying to step up a standard. So I think really when it comes to knowing what's going to make the biggest difference, your position's really key. But equally, ask your coach, ask them, where do you think I can develop most? Because it's not as simple as saying, if everyone was quicker, they'd be better. Because that doesn't work across the board. Or if anyone's much stronger, it doesn't really work that way. Obviously, if you're quicker, you're going to be better in any position. Obviously, if you're stronger, you're going to be better in any position. But it may not be the fact that will take you up a level to make you a physically better player and improve your game. So it is a little bit more complicated, but that's one of the reasons why I love rugby, because it doesn't matter what size you are. There's a position you can play and you can excel at.
Yeah. Where are you putting me on a rugby pitch, Mike?
I've never seen you sprint or run, so I'm not too sure.
Well, we won't dig any deeper into that then.
You asked the question.